My name is Mary Lloyd Ireland, and this talk is about X-rays, what plane views, and when to order advanced imaging. This was presented at the Essentials of Sports Medicine, From the Sideline to the Clinic, formerly the American College of Team Physician course, Part 2. The course was in San Diego, February 2017. The learning objectives: know the images and position of the patient to order for certain diagnoses. Understand when to order advanced imaging after plain X-rays. I have no disclosures. This is the different sections of this talk. Introduction. We'll do lower extremity starting at the hip and going all the way down to the foot, and then conclusions. Knee radiographs should also be standardized. If you can convince your partners or department to get the same views, then studies can be more easily done or patients can be compared year to year. Typically the views in the knee, you do want to get standing views. The degree of flexion can vary, but if you're consistent with a degree of flexion, then you can talk to patients with osteoarthritis and show them X-rays year to year to better counsel them on if their osteoarthritis is progressing. So the Rosenberg view is a standing 45-degree PA view that we get bilaterally. For osteoarthritis, views that are 30 or 15 degrees PA view standing. It's amazing the number of X-rays that come in from ERs that are a couple of obliques. None of them are ever standing, and these don't really give us a lot of information after, say, age 50 of if patients have some early osteoarthritis. Standing views are also helpful in younger patients for alignment and symmetry as well. Patellar views, get a Merchant or Sunrise bilateral. The lateral view should be in a similar degree of flexion each time, particularly if you're worried about the height of the patella as it relates to the patellar tendon, whether they have patella high riding or alta or patella infera or baja. Ideally, a goniometer should be used to standardize this, a lateral view in 45 degrees of flexion. And for example, if you had a lateral view at 0 degrees of flexion, the patella would be high riding, and we can't really measure the ratio needed for determining the patellar height with varying degrees of flexion. Notch views are done for osteophytes. The classic notch view is with patients up on all fours. Some people use the Rosenberg view of a 45-degree PA view as their notch view. So if you're looking to measure notches for width, as in ACL injuries or osteoarthritis, you need to make sure that the views are standardized and are comparable center to center or day to day. Try to standardize the views for all physicians. Use a goniometer. Know and communicate with your X-ray technicians. They can really help you to make a diagnosis, perhaps on plain views with marked views. Sometimes you have to get stress views. This shows the standing PA view position. On the left is 15 degrees of flexion, and on the right is 45 degrees of flexion. And the upper left X-ray show the medial and lateral clear spaces and what we see. So you can see on the less flexed, we see medial lateral clear spaces, but we really don't see the notch that well. So this is the notch, and what I like with these standing views is you can show patients the amount of narrowing if they have osteoarthritis. You look for sclerosis here, and sometimes the sclerotic bone may be a better one for weight bearing. Somebody that has a lot of osteopenic bone or has alignment this is in a bit of varus, but is alignment in valgus, that may progress more quickly to progression of valgus or varus if the bone quality is not as good. So we look at the lateral space and the medial space here in this view that's 15 degrees flexed. The 145 degrees, or the Rosenberg view, you can see how now you see the notch. So these sometimes are used as the notch views, where people can look at the notch for osteophytes or measure the notch as it relates to the notch width here and do a ratio of the distal femoral width. So some people use this as a notch view as well. So this more for osteoarthritis. You can use this as a notch view, but be consistent and make sure that the radiology techs are getting it in the degree of flexion that you want it in. So 45 degrees flexion, you can see the joint spaces as well as the notch, and 15 degrees of flexion, we don't see the notch as well. Lateral views typically are done non-weight bearing. Using a goniometer will get the degree of flexion more consistent so that you can measure the patellar height and the patellar tendon height and do ratios to determine the position of the patella, whether it's patella superior writing or alta, or patella baja or inferior. This is how a sunrise or merchant patellar view is done. Typically we do bilateral x-rays so we can compare what the trochlear groove depth is, what the patella actually looks like. The development of the patella reflects the groove. So this is a normal merchant sunrise view, and this is the jig that we use to do this. And then this is the classic notch view. We get this notch view to look for osteochondritis dissecans of the femoral condyles in adolescents. If we're measuring the width of the notch as it relates to the size of the ACL, if we have notch stenosis, we can measure the absolute width. More commonly, we measure the width of the notch and then also the distal femoral width, but the x-rays need to be standardized to get the same degree of flexion and position. If you measure the notches on a standing 45-degree flexed PA views, as in the Rosenberg view, then that's a different way to measure it, and you can't compare that with this type of notch view when they're up on all fours, which is the classic description. Osteoarthritis grading systems. There's the Kellgren and Lawrence that is most accepted. Fairbanks. Joint space narrowing. You have to get a standing radiograph. The plain radiographs underread the severity of arthritis. There also is an Ahlback classification. There are numerous studies comparing the different classifications, and there is disagreement on the definition and grading of osteoarthritis, as well as a poor correlation with patient symptoms and progression of osteoarthritis. I do think it's good to get bilateral standing views. You can look at the quality of the bone, whether there's sclerosis of the proximal tibia, whether there's a lot of osteopenia on these x-rays. Sometimes the patient with osteopenia may have progression of the malalignment and more pain than that very sclerotic varus knee. But you got to get standing views in osteoarthritis. I will show the x-rays to the patient so that they understand what is meant by arthritis and explain everything to them, and then they'll buy into the treatment plan. 45-degree flexed PA weight-bearing views is the most sensitive for detecting joint space loss. This is based on 2 studies from JOS and Clinic Journal of Sports Medicine. Imaging, plain radiographs. These are the most important investigative tool, poorly indicative of problems amenable to arthroscopy and intervention. Insensitive indicator of early osteoarthritis. So if you have somebody that has a lot of pain, the x-rays don't really look that bad, you might consider getting an MRI scan to assess the articular cartilage and any bone edema or avascular necrosis in the knee. This is a case that was sent to me with the imaging already performed. 55-year-old. She'd had difficulty walking, more to her left knee than her right knee. She fell 10 years ago, was told she had meniscus tears. In our state, we see a lot of patients of this weight. Her BMI is 43, 5 feet 5.5 inches, weight is 303. And she has arthritis of both of her knees. This is what her alignment looks like. So you can see she has varus of both of her knees, obese morbidly, has a little rotation externally at her hips. So when we look at her and her history, with her being so overweight, any meniscal surgery that would be done in this 55-year-old would not really be helpful to her, and really a disservice to put her through a surgery and potentially have problems like deep vein thrombosis, which are increased in patients who are morbidly obese. These are the x-rays. This is her left knee. So you can see she has tri-compartment osteoarthritis. These are standing views. Osteophytes here, the tibia is translated, so tri-compartment osteoarthritis, severe osteoarthritis of her patellofemoral articulation, and pretty much obliteration of that patellofemoral articulation on the lateral view. X-rays of her right knee, not much different, tri-compartment osteoarthritis. Her right knee is a little more translated than her left knee is, so severe osteoarthritis tri-compartment. So what study should be ordered next? Well, if she was a candidate for a total knee replacement, that would be the surgical option. However, with her morbid obesity, she is not the best candidate for a total knee replacement. So the primary care physician orders more tests. What tests would you do next? Should it be more diagnostic tests, MRI scan, bone scan, CT scan? Should it be physical therapy? Should it be weight loss intervention? Weight loss to be done by diet, not by exercise. Obviously, she hasn't exercised and can't exercise in a weight-bearing way, such as walking more to burn up calories because of her severe osteoarthritis of both of her knees and her weight. So what was done next was MRI scans of both of her knees, which was really not indicated and didn't change what the approach was to her treatment. So even though she has abnormal menisci, the arthritis definitely wins over menisci. So the hard tissue of the significant osteoarthritis is what the problem is. It doesn't really matter what the status of the menisci are. So I spend a lot of my time in clinic looking at MRI scans from outside images. Imaging centers may not be the best scan. So severe osteoarthritis that we could see on the plain films, or we could see in the forest view, so to speak, and now we got a lot of trees in here where the patient has read how many bad things are in her knee, such as torn menisci. She's wanting to have a scope done, which is not indicated and should not be done. And then this is all the osteoarthritis that you can see with the bone edema, and her menisci definitely are abnormal. You can also determine the thickness of this soft tissue, which goes along with her morbid obesity. So consult an orthopedist before getting an MRI scan in the morbidly obese older individual, because the MR is going to be abnormal and does not affect or change the management of this patient. More tests needed, certainly not more diagnostic imaging tests. MRI scan in the arthritic knee after age 50, not helpful for articular cartilage. Meniscal signal will usually be abnormal and will come to the tibial surface. So patients oftentimes come in thinking a simple surgery would help, when in fact modification of activity, strengthening, gait training, balance, hip core, and the last resort in this case would be a total knee replacement. MRI scan for the arthritic knee. You do want to look and see if the root of the meniscus is involved or torn. There are some indications, usually not in the patient I showed, but some healthy individuals who have no arthritis, a root repair can be done. Not as successful as if they had an ACL tear and a meniscal tear. What about my Baker's cyst is a common question. The Baker's cyst exists because of intra-articular effusion, and the fluid leaks out the back of the capsule. So the Baker's cyst isn't the cause of the problem. It reflects intra-articular swelling. A lot of patients don't understand that and want their Baker's cyst to go away and come in if they've had surgery done saying, well, I still have my cyst, can you take my cyst out? This is not indicated and reflects something going on the inside of the joint, such as a meniscus tear or arthritis. If we can do a scope and take care of the intra-articular process, the cyst goes away. So think about the forest and the trees. The trees are the MRI scan, but in the big forest, the plain X-rays show us the amount of arthritis. And that shows us the reason for the patient's pain and stiffness is arthritis. And arthritis wins over the meniscus tear. So if they have that significant arthritis, it really doesn't matter what the MRI scan shows us. Imaging the arthritic knee, use a goniometer to assure comparable X-rays year to year and also for outcome studies. Let the orthopedist order the MRI scan in the arthritic patient. There are advancements in the articular cartilage sequencing. You may want a DESS or special articular cartilage sequences in a patellofemoral problem. In most cases, MRI scans in patients over age 60 would not change the treatment plan, so are not indicated. I don't need an MRI scan to know what to do arthroscopically. I was scoping knees prior to MRI scans. We didn't really have MRI scans or know about bone bruises until the mid-80s. This is a 17-year-old with right lateral knee pain. It can be helpful to get MRI scans to determine the meniscus status. So in this 17-year-old, here's her medial tibial plateau. Here's the lateral tibial plateau. You can see the shape of the lateral meniscus. It comes way around, more like a U shape. And the tear patterns in radial tear of the horn body junction with a radial tear of the posterior root here. So this axial view can be one that shows a lateral meniscus tear. MRI scans may miss about 2% of medial meniscus tears and about 6 or 7% of lateral meniscus tears. So this is a indication for also getting better, closer together axial cuts to assess the lateral meniscus and possible cyst formation. Bone bruises. This is the typical bone bruise of an ACL tear, mid-portion lateral femoral condyle, posterior aspect lateral tibial plateau. This is what the scope looks like. Rarely, in about maybe 2% of ACL tears, do we see articular cartilage abnormality of the lateral femoral condyle. The bone bruise is deep to the articular cartilage, so the lateral femoral condyle articular cartilage typically looks completely normal, as in this case. There was a radial tear of the lateral meniscus here that we took out this portion since it was in the avascular area. And this is what the mop-in tear of the anterior cruciate ligament looks like. And this is what our notch looks like. So on the x-rays that we showed, the notch view, this is what we're looking at with the notch. So the ACL should be connected here. And if you have a small ACL, then you have a small notch. We don't really know if these bone bruises predict development of osteoarthritis. In ACL injuries, it's the lateral compartment that has the bone bruise initially, but with or without reconstruction, it's typically the medial compartment that develops arthritis 10 years down the road, not the lateral meniscus or lateral compartment. Bone bruise patterns. This is an acute patellar dislocation. The bone bruise pattern is more anterior in the lateral aspect of the patella, or in the femur, so the patella goes laterally and the patella sits here, so you have bone bruising in the medial aspect of the patella and the anterior aspect of the lateral femoral condyle. No osteoarthritis from bone bruise in the patellofemoral joint, but you can have articular cartilage injury and maltracking. This is what the hemarthrosis looks like in this acute lateral patellar dislocation who knocked off a little chunk of the articular cartilage right here. Bone bruise patterns in soccer, medial tibial plateau bone bruises can mimic a medial meniscus tear. Again, the diagnosis is possible for a bone bruise only with an MRI scan. There is no long-term risk of developing of osteoarthritis. In degenerative posterior horn root tears of the medial meniscus, the medial tibial plateau has abnormal loading, and you'll oftentimes see a bone bruise in the posterior aspect of the medial tibia if they have an abnormally functioning posterior horn of the meniscus, which means the whole medial meniscus is not functioning normally. What is the long-term follow-up for bone bruises? We need more long-term follow-up, but at this point it doesn't seem to be significant in that the size or the development of the bone bruise does not lead to osteoarthritis long-term. It's really unknown. Long-term bone bruises do not equal osteoarthritis. In ACL injuries, non-contact mechanism, acutely, lateral compartment bone bruises. The arthritis happens medially in chronic osteoarthritis 10 years down the road. Classification systems for bone bruises do need further development and further follow-up radiographically with plain radiographs. Bone bruises will stay by MRI scan for 6 or 12 months, so no follow-up with MRs is indicated. So with radiographs and with taking care of patients and interpreting the radiographs, you look for what you know and you find what you look for. So advanced imaging is definitely indicated if something is unusual, out of the ordinary. In my opinion, I would seek consultation from those who you trust, and a good orthopedic consultation is better than a lot of advanced imaging that may not give a diagnosis. Seek earlier consultations rather than getting more radiographic tests. If your orthopedist wants every test imaging done prior to being seen, I would suggest having another orthopedist as your consultant for that particular patient. Thank you very much for your attention. Water bucks in Africa.